Hi, welcome back to Nursing 121. This is Professor Erica Jones. I'm hoping that you all had a good break and that you're rested and ready to do some learning. Today's lecture is about collaborative problems, also known as potential complications. Let's get started. So, what are collaborative problems? Collaborative problems are defined by Carpenito as certain physiologic complications that nurses monitor to detect onset or changes in status. So, what really does that mean? A collaborative problem is something that a nurse cannot fix using independent nursing actions. I usually start this lecture by telling a story about a patient that I had when I was a nurse on a medical surgical unit. This patient's name was Mr. X, and of course he was a lovely, wonderful man, very pleasant, very concerned because he was in the hospital for abdominal pain. I was a nurse taking care of him on the night shift, and when I went in to meet Mr. X and I turned him on his side, I had discovered that he had had a large amount of what's described as a current jelly stool, which basically means he's bleeding somewhere inside his intestines. I cleaned him up, maintained my calm, nurse-like demeanor, and told him that he had had this large amount of stool, which looked like it had blood in it, and that I had to notify the physician about the problem. So at that point, I had the CNA get a set of vital signs. I called the provider and I told them what was going on with Mr. X. The provider said, let's get some labs, right? Because we're concerned if he's bleeding that his H&H is going to be low. And I'm going to get some tests on this patient. So I then went back to my patient, told them what the plan was, and got the labs. And the labs came back and the H&H was low. I then called the provider back. The provider said yes, they had seen the labs, they were low, and let's give some blood. And also, we're going to get a test called a tagged red blood cell study, which would show me if there was an area of bleeding going on, would show the provider if there was an area of bleeding going on. So this was an extremely busy night. I went back to my patient, explained to Mr. X that we were going to go downstairs for this study, that I was going to give him a couple units of blood, and went on with the rest of my shift, trying to make sure my other patients were well cared for, checking the blood with another nurse, hanging the blood, making sure that the patient tolerated the transfusion fine, calling the nuclear med department to schedule his tagged red blood cell study, and then once the time was set, transporting the patient downstairs and monitoring him and making sure that he was doing okay. A big part of taking care of a patient with a collaborative problem is you are going to implement the provider ordered things that you need to do for your patient, and you are going to monitor and make sure that your patient does well with these different interventions. So your job as the nurse, remember that you are watching and paying attention to your patient, and you have a duty to notify that provider if things happen that you aren't going to be able to fix as a nurse, and especially if stuff changes quickly. So to complete my story about Mr. X, I took him downstairs to the tagged red blood cell study. Now, I had been to a lot of these studies. They're kind of boring. They give your patient some dye in their blood and they kind of watch while the blood runs through the patient's system. I would say that I had been to, I don't even know how many nuclear medicine studies like this. This was the only one that I saw that was positive. So you could actually see when you were looking at the nuclear med study, an area in Mr. X's belly. You could see an area, it was like near the mesenteric artery, where he was actually bleeding. And I knew that this was an active problem because I had already given him 2 units of blood and changed him probably 3 or 4 times for more large kind of currant jelly looking stools. So it was clear that he had ongoing bleeding and that this was not something that I was going to be able to fix on my own. So I saw the study was positive, went back upstairs, called the provider again, settled Mr. X into the bed, made sure his vitals were stable, made sure that he was doing okay. And at this point, his blood pressure was a little bit low and he was starting to get a little bit confused. So that was a new change for him because he had been very with it up until this point. So I called the provider, told them about the study. We had sent more labs after the transfusion, which had come back even lower than the previous labs. So the provider said, I'm going to send him down to interventional radiology where maybe they can embolize this artery that's bleeding, and you're going to give him 2 more units of blood and make sure that he tolerates this well and keep an eye on his vital signs. So I checked again on all my other patients to make sure that they were still doing okay. Thank goodness he was my only sick patient that night. And then I got the blood, called IR, scheduled, made sure that the schedule meshed, that they had time to take him, that he understood what was going on, and brought him down to IR. Now, in the interventional radiology suite, the doctor attempted several times to embolize the artery, but it was so far out on the edge of the kind of bed of arteries that you have in your belly that they were unable to reach it. So he spent probably an hour downstairs in IR. I was with him because at this point he was on a cardiac monitor and we were monitoring his blood pressure closely. And the IR physician notified his primary physician that I had been talking to and said, I can't embolize this. The patient's going to have to go to surgery to fix this. So we took Mr. X upstairs again. I got more labs on him and talked to the provider about the situation in IR. He had already heard from the IR doc and said, we're going to have to prep him for surgery. And so when I went to give this information to Mr. X, he was a little less confused at this time. He had gotten 2 more units of blood and he had perked up a little bit. He said, I have a surgeon. I know who I want to do my surgery. Let me call him. So Mr. X called his friend, the surgeon, and I told the primary care doc that he wanted this person to do his surgery. Luckily, they had privileges there, so it all worked out fine. And by the time I was going home at 7 in the morning, the surgeon had come into the hospital and had already made plans to take him to the operating room to fix that problem. But that is an example of a patient who definitely had a collaborative problem. It was something that the nurse had to do a lot of monitoring and interventions to try and help the patient get better. And a lot of what you do when you have a patient with a collaborative problem is monitoring and minimizing the complications. So if I had not notified the physician at the start of my shift when the patient obviously had a problem, and I had waited until he had become confused, we could have been dealing with a much more serious situation. But because I was monitoring him closely, I was conversing with the provider often, we were able to do those interventions, give him 4 units of blood, get these studies done, and the patient was all set to go to surgery in the morning without having had significant hemodynamic compromise, despite pretty robust GI bleeding for most of the night. So remember, you as the nurse, it's your responsibility to report those abnormal findings and changes quickly to the provider and then implement whatever interventions the provider says, we need to do to get these patients better. Unlike a nursing diagnosis, the prescription for the treatment of a collaborative problem will come from nursing and medicine and other disciplines. Also known as potential complications, abbreviated as PC, they must be identified early so that this preventative nursing care can be instituted early. And they usually require pretty pretty intensive monitoring to make sure that you don't miss a collaborative problem or a potential complication. Just think about that name, potential complication. It means that something could possibly go wrong. The fact that your patient is needing medical care, I don't care where they are, if they're in the acute care setting or the long-term care setting, the fact that they need care from nursing, that to me indicates that there are many things that could go wrong with your patient. So make sure you monitor them closely. So how do you identify a collaborative problem? You have to understand the pathophysiology of what's going on with your patient and the potential complications of medical treatment of that patho. So, for example, if you're taking care of a patient who has heart failure, you should understand, based on your understanding of pathophysiology, that your patient could have possibly fluid on the lungs, possibly they could become hypoxic, they could have dysrhythmias because of their heart failure, and they could certainly go into cardiogenic shock because of their heart failure. Now, these are all, bad situations. They're all complications. But you as a nurse should understand that when you're taking care of a patient with heart failure, these are potential things that could go wrong with your patient. Why do we call them collaborative problems or potential complications? If you classify certain clinical situations as collaborative problems, it helps to minimize the misuse of nursing diagnosis, especially because if a nurse cannot prevent or provide the primary treatment for a potential complication, it's not a nursing diagnosis. It's a potential complication or a collaborative problem. The nurse should recognize and report any changes in patient condition that may signify a problem. This is one of the reasons why we tell you to look at trends when you're taking care of a patient. If I have a patient that I know is a dialysis patient and they typically run a low blood pressure with a systolic in the 90s, if I get a blood pressure of 89/54, I'm going to look back at the trends and say, he normally runs in the 90s. 89 is really not too far off this patient's baseline. If my patient's normally hypertensive with a systolic in the 140s or 150s, and the CNA comes to me and says, Mr. Smith is now 89/57, my alarm bells should ring in my head and I should say, I should probably notify the doc because that's pretty far off his baseline. Collaborative problems can have many, many different causes. They can be physiologic complications of a patient's disease, like the heart failure example. They can be a complication of a test. For example, if I had taken my patient for a CAT scan and they had gotten contrast and they weren't adequately given fluids, they could have kidney issues because of the contrast that was given to them in the test. They could be a complication of treatments. If my patient downstairs in IR had, if the interventional radiologist had, injured one of the blood vessels, he could have had a complication from that treatment. They are always oriented towards pathophysiology. They are nurse and provider diagnosed, and the provider orders the definitive treatment for them. So for example, my patient with heart failure, if they end up with pulmonary edema, the nurse notices the patient is short of breath, the patient has an oxygen saturation of 89, the patient is reporting they're having trouble breathing, and on auscultation I hear crackles in the lower lung bases. The nurse says, my patient has heart failure. It's possible they have fluid on their lungs. I'm going to call the physician and let them know. So the nurse calls, does a beautiful i-SBARQ report, notifies the provider that I think the patient's having pulmonary edema. The provider says, yep, I think you're probably right. Let's give a little bit of Lasix. So the provider is going to be the one that orders that definitive treatment. The nurse isn't going to be able to order Lasix for her patient because it's outside of their scope of practice. The provider is the one that has to order the medication. Independent nursing actions allow for both monitoring and preventing of collaborative problems. And there are dependent nursing actions, such as the nurse giving the Lasix, for treatment. They are present when there's a disease or a situation present. Pretty much a collaborative problem can happen to anyone at any time, and there's no classification system used. So what can a nurse prevent? The nurse can prevent injury. Patient has a nursing diagnosis of risk for injury. Nurses can prevent fluid volume depletion. The patient has a nursing diagnosis, risk for fluid volume deficit. The nurse can prevent pressure ulcers. The patient has a nursing diagnosis of risk for alteration in skin integrity. Nurses can treat immobility. That's a nursing diagnosis, impaired physical mobility. Nurses can treat malnutrition. Patients can have a nursing diagnosis of altered nutrition, less than body requirements. And nurses can treat pressure ulcers. They have a nursing diagnosis of impaired skin integrity. What do nurses do with collaborative problems? They focus on monitoring and reporting to the physician provider any change in health status. They respond by performing both nurse-prescribed and provider-prescribed treatments. And I love this meme because it's so true. If anyone's ever worked in acute care or in long-term care, how often do you see the physician? Seriously, when I care for patients as a nurse practitioner, I see them once a shift. Unless they're sick and I have to monitor them frequently, but I will do one physical exam, I will do one neurologic exam, and the rest of the time it's that nurse that's in and out of the room for the whole 12-hour shift. When the nurse comes to me with a problem, I go. I make sure, I assess the situation, see what's going on, and if the patient needs medical treatment, as an advanced practice nurse, I can prescribe that. During the 23 hours and 55 minutes a day when your doctor's not in your hospital room, it's going to be your nurse who saves your life. That is never more important as with collaborative problems, because a good nurse can see a problem miles down the road, and early notification and early intervention can make a big difference for these sick patients. If we were in the lecture hall, I would have you all responding, when we talk about collaborative problems, you need a team. If you're the nurse caring for your patient with heart failure and they become short of breath and drop their O2 sat, what do? You sit the patient up, make sure they're in high Fowlers, make sure that they can cough and deep breathe in case it's secretional. Those are independent nursing actions. That's all you. You place oxygen on the patient per the provider's order. That's a dependent nursing action because you need an order to do that. You're going to monitor their respiratory status. You're going to listen to their lungs. You're going to get their O2 sat and see that it goes up once that oxygen gets put on. You're going to also notify the provider that the patient is having dyspnea and hypoxia, reporting an acute change in the patient's condition. The provider might say, let's get a chest x-ray on this patient, and the chest x-ray is done and they look wet on the x-ray. The provider then might say, let's give Lasix 20 milligrams IV, and you're going to take that medication from the Pyxis, you're going to draw it up, and you're going to give it safely to your patient. Collaborative problems need a team approach to treat. So what's the difference between nursing diagnoses and collaborative problems? With nursing diagnoses, nursing prescribes the definitive treatments. With collaborative problems, the treatments are both nurse prescribed and provider prescribed. these are a few more of the differences between collaborative problems and nursing diagnoses. With a nursing diagnosis, the assessment involves data collection to identify actual or risk nursing problems. With collaborative problems, assessment focuses on determining the patient's physiologic stability or risk for instability. So you are using your critical thinking skills. When you get those patients that have heart failure, your brain is going to say, I need to watch for pulmonary edema. I need to watch for dysrhythmias. These are the potential complications of this patient's pathophysiology. The client outcomes or goals are used with nursing diagnoses, but not with collaborative problems, and we'll talk about that more in a bit. The general intervention for potential complications, also known as collaborative problems, are the nurse will monitor for onset or early changes in status. The nurse will initiate provider-prescribed interventions as indicated. The nurse will initiate nurse-prescribed interventions as indicated. And the nurse will evaluate the effectiveness of these interventions. The focus of the outcome or goal with a collaborative problem, like I just discussed, those four things are nurse-oriented. The nurse will minimize and manage and minimize the risk of hypoxemia. So she's assessing her patient in this photo, and you can see she's listening to lungs, making sure that the patient's lung sounds are clear, and she's going to manage and minimize the risk of hypoxemia in this patient. Maybe this patient was admitted with a COVID pneumonia, and it's the nurse's role to make sure the patient doesn't decompensate. This is a nice decision tree that you can use to decide if your problem is a nursing diagnosis, if it's a medical problem, or if it's a collaborative problem. You can review this after. So we have a couple examples going forward. Example one is a patient with heart failure. They were admitted to the hospital with an O2 sat of 92% on 2 liters. And the patient says they don't use oxygen at home. So that's your first indicator that this is a problem for the patient. In addition to the nursing diagnosis, risk for ineffective health maintenance related to insufficient knowledge of CHF diet and medication adherence. Perhaps the patient had a big ham dinner and didn't take their Lasix yesterday. The patient would also have the collaborative problem diagnosis, potential complication, hypoxemia. That's it. There's no related to statement required, but it may be added for clarification. So your potential complication documentation is basically the patient has a physiologic problem of heart failure. Your potential complication is hypoxemia. And then all of your interventions are nurse-related goals. On initial assessment, this patient's breathing 24 a minute and they have slight expiratory wheezes. He can converse with you without pausing for breath. After lunch and 240 cc's of fluid intake, the patient's now hypoxic with an O2 sat of 87% on 4 liters, and he's unable to complete a sentence. If you've ever had a patient with bad respiratory disease, you know what that's like. They tell you their name is Mr. Smith, and they just can't get out the words without having to stop for a breath between. This is a patient in respiratory distress. You'll listen to the patient's lungs. There's crackles present halfway up both lung bases. Respirations are 34 a minute, which is pretty quick. Because you know this patient had a potential complication of hypoxemia due to his CHF, you are monitoring those lung sounds and his O2 sat, and you're able to notify the doc immediately. You get a stat order for Lasix 40 milligrams IV. You give the medication and monitor the urine output and improvement in patient's breath sounds and oxygenation. And all of these collaborative problems, all your examples are going to be relatively straightforward. You're not going to have a patient like Mr. X right off the bat. but understand that patients' pathophysiology can be complex, and it can be more than 1 or 2 or 3 or 4 things wrong at a time with a patient. An hour after you give the Lasix, your patient's voided 500 mLs of urine and they're breathing again at 24 breaths a minute. And now their SAT's 94% and you've been able to turn their oxygen down to 2 liters. The patient denies any pain or dyspnea, but he calls you to report a fluttering feeling in his chest. He has a standing order for an EKG. You obtain it. That's a dependent nursing action because you had a physician's order for the EKG. And you notify the doc, you got this EKG, the patient has a fluttering in his chest, it's new, and the doc says, get some labs. The EKG shows some abnormal beats, and the physician comes to see the patient and review both the EKG and the labs. The patient's K is down to 3.2, and you receive an order for potassium 40 milliequivalents PO now. You give the medication and continue to monitor the patient for additional complications. All right, so here's your second case study. This patient has diabetes and they've been admitted to the hospital. Blood glucose is 341. In addition to the nursing diagnosis, risk for ineffective health maintenance related to insufficient knowledge of diabetes diet and medication adherence, the patient would also have the collaborative problem, potential complication, hyperglycemia. And that seems like it's very straightforward, right? Your patient has diabetes. They're going to be at risk for both of these potential complications. There are potential complications because the treatments are not nurse-driven. The treatments will be driven by medications which are ordered by the provider. And there's the nurse. She's so happy to start her shift today. So the endocrine NP admits the patient and starts a basal dose of Esculantis daily, as well as a sliding scale of Lispro to be given before meals and at bedtime. Point of care glucose checks are ordered before meals, at bedtime, and at 3 a.m., plus as needed for signs of hypo and hyperglycemia. A carb counting / diabetic diet is ordered. The patient's sliding scale insulin is 10 units of Lispro for a glucose of 341. You give the prescribed dose and monitor the patient, who reports she isn't feeling great and only picks at the lunch delivered 10 minutes later. An hour after the Lispro, the patient reports feeling dizzy, anxious, and she's diaphoretic. You check the patient's glucose because you have an order for PRN for any signs and symptoms of hypoglycemia, and it's 42. What's your plan as a nurse caring for the patient? You know this from last semester, right? What should you do if your patient has hypoglycemia? She's awake and she has a diet ordered. You're going to bring her 8 ounces of orange juice and graham crackers with peanut butter. She drinks the juice. You call and notify the nurse practitioner, who adjusts the sliding scale insulin and orders Q2 glucoses for the next 6 hours. Her glucose is up to 73 in 15 minutes, and the patient feels much better. She eats the graham crackers and the peanut butter with a glass of milk. You use this opportunity to teach the patient the importance of eating after insulin administration and the signs and symptoms of hypoglycemia. Where do collaborative problems fit into your nursing process? So we know nursing process is ADPI, assessment, diagnosis, and after diagnosis, you're going to develop your patient's problem list and come up with your nursing diagnoses that fit that patient's problems. At the same time, you are going to develop a collaborative problem or more based on your patient's medical diagnosis, pathophysiology, or any test or treatment that they've had. After that, planning, implementation, and evaluation take place. And remember, while your nursing diagnoses have patient-centered goals, your collaborative problems will all have nurse-focused goals. The nurse will monitor and minimize hypoglycemia. That's it. The nurse will do this by checking blood glucose, monitoring the patient for signs and symptoms of hypoglycemia, administering 15 grams of quick-acting carbs for any glucose less than 60, notifying the provider for any hypoglycemic episodes, administering dextrose should the patient be unconscious and unable to take PO. How do you develop a collaborative problem? The collaborative problem statements need to be incorporated into the problem list as part of the nursing process. The focus of a collaborative problem is prevention of the potential complication, and it is nurse-oriented. For example, the nurse will manage and minimize the effects of hypoglycemia. What are the components of a collaborative problem? It's actually pretty straightforward. You have a collaborative problem statement, and this one is potential complication, increased intracranial pressure. The goal is the nurse will manage and minimize the effects of increased intracranial pressure. That's it. The nurse is responsible for knowing this is a potential complication and managing and minimizing that. The interventions for this collaborative problem, you're going to monitor that patient's neuroexam every 2 hours and report changes. You're going to monitor vital signs every 2 hours and report abnormalities. You're going to keep the room environment quiet. Make sure this patient doesn't have any increased intracranial pressure. Collaborative problem interventions include monitoring and reporting specific findings using the i-SBARQ technique or the CUS technique if you don't get anywhere with i-SBARQ, and we'll talk about that. Nursing interventions are both nurse prescribed and physician prescriber prescribed. So for example, your patient with heart failure who's hypoxic, the nurse is going to sit them up high, instruct them to cough and deep breathe, and they're going to apply oxygen, both nurse and provider prescribed interventions. Reminders about communication. Assess prior to calling the provider. My example of my patient with a low blood pressure, I would make sure that I went and assessed that blood pressure myself using a manual cuff before calling the provider, because I need a full assessment. I can't just call someone and say, Mr. Smith's blood pressure is 89/57, because I want to know, what do they look like? Are they pink and awake and alert and well perfused, or do they have a gray coloring? Are they sweaty? Do they look like crap? I want to know what to tell the provider when I call. Assess and do a thorough assessment, a full set of vital signs, do a quick neuro exam, listen to heart, lungs, and belly. Already know in your head what are the important points of your communication before you call. Use the i-SBARQ communication method, and this is illustrated in your Treas book, page 495. The components are, it's basically i-SBARQ with an introduction in the beginning and a questions at the end. So you're going to introduce yourself. Hi, my name's Erica. I'm one of the nurses on Springfield 2. I'm calling because this is my situation. Mr. Smith has a low blood pressure and he doesn't look great. He's diaphoretic, his skin has a gray cast, and he's complaining that he's short of breath. That's all I need to say. That paints a pretty good picture for the provider of what I'm looking at. Background: Mr. Smith was admitted yesterday for abdominal pain to my unit. He has a past history of heart failure and COPD. He takes lisinopril and Lasix at home. Assessment: state the problem and your assessment, especially any changes from prior. So my assessment is, as mentioned, he's gray, he's diaphoretic, he was not looking like that when I assessed him first thing this morning, and he has this new onset of chest pain. Recommendation: possibly we should get an EKG on this patient, as he might be having a cardiac event. Make sure that you have an idea in your head of what you're looking for so that you can make a recommendation. Sometimes when you call a provider, they're not going to have any clue about the patient, especially if they're covered under a large team of hospitalists. If the patient is known by the provider, it will make your life a lot easier, but that's not always the case. Then make sure that you allow an opportunity to ask and to answer any additional questions. Do you have any questions for me? And the physician might ask, can you tell me the patient's code status? Are they a full code? Do they have any family at the bedside? Have they ever experienced these symptoms before? Do they have any cardiac history? And you as the nurse should be able to have the patient's chart open and be able to find that information quickly. These are some examples of collaborative problems. Hypovolemia, hypoxemia, medication therapy, adverse effects. Anytime you give a patient a medication for the first time, make sure that you're monitoring them because they could potentially have an allergy. Hypoglycemia and anemia. These are all examples of collaborative problems or potential complications. All right, so here's another case study. Mrs. Q, she's a 78-year-old lady admitted to your unit for a COPD exacerbation. She is oxygen dependent at home and she wears 2 liters of oxygen. On exam, she's anxious, she has diminished breath sounds, and she appears malnourished and tired. Her vitals on admission, she has a low-grade temp of 99.3, heart rate is 105, her blood pressure is 133/85, she's breathing 26 times a minute, and her oxygen sat is 87%. That should be SpO2, it's not an arterial oxygen sample. So what's your nursing diagnoses for this woman? Potentially nutritional deficiency less than requirements. Could be that she has an educational deficit about her nursing, about her COPD. And what are 3 potential complications of COPD? Those will be on your list of collaborative problems. So potential complications of COPD, I can see one staring me in the face. She's hypoxic, so her oxygen sat is 87. We don't know kind of where she lives. Sometimes COPD patients maintain an O2 sat of like 90 at baseline, but 87 looks a little low for me. Another complication of COPD is definitely anxiety. So the patient might need some medication for anxiety because when people have difficulty breathing, it makes them very anxious. She could also have heart failure as a result of her COPD exacerbation, so she could end up getting fluid overloaded. She could also be at high risk for infection because of her COPD. These patients often have repeated courses of antibiotics because their lungs are kind of shot and they get frequent pneumonias. So what are your interventions for all of these potential complications? You know your patient has COPD, you know they can have this list of problems. What are you going to do for them? The nurse will monitor and minimize effects of hypoxia, heart failure, anxiety. Case study number 2, a stroke. So Mr. Y is an 80-year-old male. He was admitted to your unit for an acute stroke. His wife found him on the floor this morning, not moving his right side and unable to speak. On exam, he's restless, nonverbal but alert, still not moving the right side, and he's looking to the left. He does not follow commands, but his vital signs are stable. What are your nursing diagnoses? Ineffective self-care due to hemiplegia. He can't move his right side. Ineffective communication because he can't speak. What are 3 potential complications of CVA? So a stroke. If you look in your nursing diagnoses handbook, there's a spot for collaborative problems related to medical diagnosis. If you look up stroke, it's like everything, including coma and death, because if your brain is damaged, it's going to affect every other system. I lecture on stroke later on in the semester, and we'll talk more about that then. But 3 potential complications of stroke: seizure. Sometimes patients who have strokes can have a seizure. Increased intracranial pressure, depending on the size and the extent of the stroke. And could be dysphagia. The patient could have inability to swallow. They could also have respiratory failure and need emergent intubation. So stroke patients can get sick pretty quickly. And as the nurse, your interventions will be, the nurse will monitor and minimize potential complications of stroke. So the nurse is going to monitor for seizures. If a seizure occurs, they're going to give PRN medication if it's ordered, or they're going to notify the provider and get medication for that seizure. The nurse will be making sure that these potential complications don't happen, or if they do, they're going to be on the lookout and ready to take action. Okay, our case study number 3, Mrs. V is a 46-year-old lady. She was admitted to your unit after having a laparoscopic cholecystectomy. The case was uneventful and she's awake and alert. The pain is being controlled with 2 milligrams of morphine as needed for pain every 3 hours. Her vitals are 98.9, 120/55. Her heart rate's 90. Her respiratory rate is 13. And she's setting 96% on room air. What are your nursing diagnoses? So, nursing diagnoses for postoperative chole may be knowledge deficit related to dietary changes after chole. Could be risk for inactivity due to postoperative pain. So you're going to make sure that you treat her pain well and get her up and moving around. 3 potential complications for this patient post-op after a lap chole. Hemorrhage. I would be worried that something got nicked or that something was missed. She could have certainly a hemorrhage after her operation. Any operative situation, you always want to be on the lookout for complications of surgery, one of which would be hemorrhage. Also, you want to make sure that she doesn't have ill effects from anesthesia. She could end up with an ileus after having anesthesia. So you're going to monitor her bowel sounds, make sure that she is passing flatus, advance her diet slowly, and make sure she can tolerate food. And postoperative pain is definitely a collaborative problem. So you're going to give pain medicine as ordered. You're going to monitor for any increase in postoperative pain that's not controlled with that medication. So the nurse is going to monitor and minimize effects of, any potential complications of laparoscopic cholecystectomy. And here is our last case study. This patient has hepatic encephalopathy and alcohol withdrawal. Mr. P is a 62-year-old guy with a history of alcohol abuse who was admitted for hepatic encephalopathy. His last drink was yesterday, and he drinks 12 beers a day. He tells you he drinks 12 beers a day. He may drink more than that because people typically lie about their alcohol intake. He has Ativan 1 milligram every 4 hours ordered for alcohol withdrawal prophylaxis. And he's sleepy, but he awakens to your voice, and he's oriented ×2. He tells you his name, and he tells you he's in the hospital, but he doesn't know the day. He doesn't know the situation. He's just a little confused. What are your nursing diagnoses for this patient? You are going to make sure he is safe. He is at risk for injury because of his hepatic encephalopathy and alcohol abuse. You're going to make sure that he has probably knowledge deficit related to continued use of alcohol despite, liver damage from that. And 3 potential complications for this patient with alcohol withdrawal and hepatic encephalopathy. So the fact that he has liver damage means that he's at risk for bleeding. So I would put hemorrhage on your list because he has a history of alcohol abuse and he has just had his last drink yesterday. I would put definitely alcohol withdrawal syndrome. So he could get delirious. And he also could have a seizure related to alcohol withdrawal. And what are your interventions? The nurse will, say it with me, monitor and minimize the effects of alcohol withdrawal. The nurse will monitor and minimize any hemorrhage that occurs. The nurse will monitor and minimize seizures. Those are your interventions. For seizures, you're going to monitor for them. If a seizure occurs, you're going to notify the provider and administer the ordered medication. For alcohol withdrawal, you're going to monitor the extent of the patient's alcohol withdrawal. You're going to administer medications ordered by the provider. You're going to provide safety using nurse prescribed interventions, maybe pad the bed, make sure that the patient is close to the nurse's station, implement frequent checks on the patient. Those are all your interventions for this collaborative problem. And that's all I got. Please take a look at your readings in the Treas book, and especially in your nursing diagnosis book. And I wish you luck in your clinicals this semester. If you have any questions, don't hesitate to reach out to me at eljones@stcc.edu. Thanks so much.